Good morning. Thank you, Sama. I'm trying to share my screen, all right, and start my presentation. I have been asked to kind of slow down in the speech, so I'll try to stick with the time as well. I'd like to thank Dr. Adrian for the opportunity to be here today. My practice is focused on medical and in-office surgery for otology, neurology, audiovestibular medicine. What I'd like to share with you today is a little bit of information about this area, demographics, risk factors, relevant anatomy and physiology, clinical history and office exam, differential diagnosis, treatment, and more important, the multidisciplinary approach and triaging. And in terms of demographics, age and gender are important to keep in mind. 1 to 3 per thousand newborn are essentially deaf, if not severely handicapped. That ratio differs from one country to the other. 15% of school-age children need hearing aids and speech therapy. Genetics is a factor. In general, male children have more hearing loss than female. Ethnicity and socioeconomic status are also contributing to problem. What are the risk factors? Family history is important. Premature, low weight gain, infections, ototoxic medications, head and sports trauma, with and without concussion, vestibular migraine, Meniere's disease in children, it does happen, and orthostatic hypertension, noise exposure as well. So when we talk about the anatomy, we like to divide external ear, middle ear, inner ear, and the related brain structures. These systems allow us to hear and speak, skillful communications, balance, spatial orientation, postural stability, in addition to activities of daily living. Everything we do is related to the point that it's actually important for survival. So hearing disorders, when we talk about the external ear, the symptoms are essentially pain, hearing loss, pressure, and differential diagnoses include earwax, swimmer's ears, common stuff we deal with, acute and chronic otitis media, with and without effusion, eustachian tube dysfunction, whether it's due to allergy, viral, bacterial, or to large tonsils and adenoid. In exam, otoscopy and tympanometry are very critical. And if nothing else, these two elements must be evaluated. ENT referral is critical, especially if tympanometry is flat or if we have obviously large tonsils and adenoids. Local treatments for earwax, swimmer's ears, no systemic antibiotics, please. And in terms of eustachian tube dysfunction, allergies, nasal decongestants, and steroids, pain medication, but no strong pain medications, and antibiotics if indicated. Obviously, audiometry and speech therapy are important, particularly when you're dealing with a child in the developing age. The inner ear, in relation to the brain, we're talking about hearing loss, mixed hearing loss, sensorineural hearing loss, and central auditory processing disorder. The office exam here is essentially normal, and again, the multidisciplinary approach, ENT, pathology, optometry, speech noise, testing, CAT scan, and ear when indicated, hearing aids, quantum equivalent worldwide, office and tympanic perfusion when needed and indicated, and speech therapy. And these kids hopefully will be in a regular classroom education. When it comes to vestibular disorders, it's a little bit more complex anatomy and inner ear, the brainstem, cerebellum, and systemic diseases as well. Dizziness and motion sickness, those are the two major symptoms we deal with. Again, vestibular migraine is important, Meniere's disease, plus or minus benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo is not a disease. It's a symptom and can be associated with several inner ear problems, not only vestibular migraine or Meniere's disease, but things like congenital abnormalities of the inner ear as well. Orthostatic pressure hypertension, hyperventilation syndrome, common in kids, large vestibular aqueduct, superior canal dehiscence, and POTS, partial orthostatic tachycardia syndrome. All of these can present with the symptom of I am dizzy, doctor. The office exam and treatment is a little bit more challenging, particularly when it comes to treating the symptom of BPPV and migraine. Again, the multidisciplinary approach is critical. Pediatric neurology, neurotology must play a role with these patients. Again, comprehensive audiometry, speech and noise, CT, MRI, hearing aids, cochlear implant, speech therapy, office tympanic perfusion. Here, restricted contact sports, particularly patients with superior canal dehiscence. Cardiology, especially when you're dealing with orthostatic pressure hypertension. I'm sure most pediatricians would be able to handle that as well. But when it comes to POTS, which is an autoimmune in basic pathophysiology, I think cardiology would be the way to go. The vestibular exam, maybe some of you have seen that. You do basically using video goggles to look at eye movements. And here's some of the nystagmus we look at. Here, for example, the system is, oh my goodness. I don't know. Things happen, I suppose. All right, or go back here and let's just see one of the nystagmus. Okay, the videos somehow are not linked, but we do vestibular exam focusing on the presence or absence of responses, particularly benign positional vertigo. In evaluating these patients, particularly those with large vestibular aqueduct, as you're seeing it here, or superior canal dehiscence, CT is really the most important part, in addition to the history and physical exam as well. And we do audiometry. In this instant, the acoustic reflex is very important because you have a conductive hearing loss and you'd like to know whether this is an otosclerosis or not. Actions are very critical. The diagnosis actually is pretty straightforward, and the treatment, first order of treatment is no contact sports, and then there could be additional surgeries that can be done. Pressure equalizing tube is really easy to do in the office when indicated in patients where they are sensitive to pressure-induced symptoms. I'd like to end up with a pediatric dizziness case because it has a lot of lessons to learn. I've seen that patient in Egypt when I was visiting several years ago before COVID. This is a 16-year-old with 1 year inability to ride bike and feeling clumsy. It's just not feeling right. New headaches and visual changes, no hearing loss or fluctuation. I saw him after almost a year having multiple audiovestibular studies, tests, and vestibular rehab for presumed BPPV. No improvement, and if anything, is getting worse. Lesson number 1, that's for particularly ENT, audiovestibular medicine, and to pediatric physicians as well. Peripheral vestibular dizziness usually respond to rehab within 4 to 6 weeks, not months, especially if there is no hearing problem. Physical exam, this patient had normal otoscopy, bilateral, symmetrical, sensory neural hearing loss, 100% word discrimination, normal tympanometry, acoustic reflexes, symmetrical VOR, no BPPV or any abnormal nystagmus. However, this patient was dysarthric, is walking with unsteady, supported, wide-based gait, had gaze-evoked nystagmus. Sorry, it's 3:30 or 4 o'clock in Cleveland here. He had distorted pursuit tracking and what we call failure of fixation suppression. They cannot suppress vestibular signal. You're more familiar with finger to nose and random alternating movements are normal. No BPPV. Motor was good, but he has diffused hyperactive dependent reflexes. Clinical exam is consistent with midline cerebellar lesion. No prior exams that I could ascertain at the time, but probably his exam was the same a year ago based on the history. So lesson 2, the history and physical exam are keys to guiding clinical decisions, primary diagnosis, investigations, and treatment. This is the patient MRI, and it won't even take a medical student to realize that there is something big in the center of the brain, and it's a midline cerebellar tumor with obstructive hydrocephalus. Lesson 3, follow-up clinical exam is more sensitive and informative than other tests, especially if progress is actually getting worse. We're physicians, we rely on clinical examination and the appropriate history. Unnecessary vestibular testing and extended rehab sessions delayed proper diagnosis and treatment in this trial. The child needed urgent referral to neurosurgery, which was secured. However, sadly, the patient died while waiting for surgery. This is a patient that should not have died. In all likelihood, this kid would have been alive if the multidisciplinary approach was taken into consideration. We must, that's lesson number 5, we must have low threshold in referring children to pediatric neurology, pediatric neurosurgery. ENT physicians play a role here to help in the appropriate triaging. And philosophically, I guess, as you get older, you get more philosophical. We really must learn how to treat patients the way we would treat our own family members, particularly in children. Take-home messages. Auditory vestibular diseases and disorders are common in children. By the way, hearing loss is the most common sensory deficit in the world, and that also includes in children. Early detection and prevention are critical. History, physical exam, and selected investigations are very important. Low threshold of imaging, especially with normal hearing patients. Early treatment leads to very reduced long-term disabilities. Multidisciplinary approach is essential. I cannot emphasize that. Pediatricians, ENT, audiology and speech, neurology, neurosurgery, psychiatry and psychology as well. Virtual consultations, by the way, which I have been doing for the since COVID, are really associated with early treatments and reduction of long-term disabilities as well. In our practice, you can use phone or email to our patients, not you, unless you have difficult cases, which I'm very happy to help everybody deal with. With that in mind, I hope I'm on time, and I'd like to again thank Dr. Adi Riyad organizing a committee for their kind invitation. I'd like to ask my dear brother Osama for chairing the session and the other members of the panel, and I'm happy to address any questions if there is any. Thank you very much.
Mohammed, thank you very much. الحقيقة sticking to the time, we still have 4 minutes, so we حضراتكم لحد عنده أي سؤال؟ I have a comment actually. احنا الام دي تي في مصر صعب جدا. انت بتبقى في مستشفى بره، فانت you are working in one place with all the specialties, and some hospitals بره by law عندهم ام دي تي اللي هو مالتي ديسيبلينري تيم، لازم العيانين دول يتشافوا باي تيم اوف بروفيسورز او كونسلتنتس وات ايفر. فاحنا ما عندناش حكايه في مصر. فاحنا انا بعمل ايه الحقيقه؟ انا بكلم الدكتور عادل او اكلم الدكتور بتاع نيرولوجي او اكلم ايفن والعيان قاعد قدامي اكلم الدكتوره ساميه اقول لها عندنا كذا كذا عايزين نعمل كذا. فالحقيقه فيري امبورتنت. my other comment actually انا الشهر اللي فات جالي طفل عنده 13 سنه has been seen by doctors being dizzy. كلمه ديزي في الاطفال دي كلمه حقيقه اصعب من الكبار. and he was put on betahistine, and I know that Muhammad doesn't like betahistine too much, has been seen by many doctors given betahistine for months، يعني 3-4 شهور بياخد betahistine. وبعدين we came back to me وبنساله الحقيقه السيمتومز بتاعته زي ما الدكتور محمد بيقول what directing me towards ان عنده بيجي له fainting attacks مش بيجي له dizziness. he ended up انه عنده ventricular septal defect وراح عمل كاردياك سيرجري. يس. فاحنا the message to the young doctors لما يجي لك عيان وخد روشته وما تحسنش، وبعدين واحد زميلك خد روشته ثانيه almost the same like the first one وما تحسنش، وخدنا الثالثه وما تحسنش، please do investigate, ask your colleague. يعني الموضوع very simple. الروشته الرابعه
You're absolutely right, Osama. I'd like to add that you have particularly dizziness. Okay, I think the hearing is much easier to deal with. But when a kid is saying, I'm dizzy, and the family is very concerned, if you don't have a diagnosis, primary diagnosis, please send the patient to a specialist, because dizziness in children, as you have seen, this case was not the only case I have seen during my repeated visits in Egypt and the Middle East during my career. So, especially if they don't have any hearing loss but dizzy, we must pay more attention to them. Are there any other questions? And again, we have the kind of privilege of being in the field for years. There's nothing wrong about saying, I don't know. Let's send you to somebody who actually can help your kid.
Muhammad, thank you very much. We come to the end of this session.
Thank you.
Next time.
Appreciate it. It's a great session. I'm learning new things from you guys.
شكرا.
خالص شكر للأستاذ الدكتور عادل رياض الدعوة